Hey there. Good morning, everybody. Dwayne Spencer here. Want to be courteous of everybody's time, so we're going to go ahead and get started here. I'm happy to see all of you showing up. Good morning. Good morning. So again, for those who don't know me, I'm Dwayne Spencer. I'm the president and CEO of Habitat for Humanity here in Memphis. So welcome to our Health and Housing Summit webinar series. We have been planning this for more than a year, and we're so excited to actually get started. First, I want to recognize the sponsors who helped make this event possible. First, Tennessee Housing Development Agency, Wells Fargo, and Methodist Lebanon Healthcare. We also want to acknowledge our advisory group who provided their expertise during the planning process. Thank you to all of you. I just want to tell you a little bit more about our aging in place work and what led us to plan this event. So it's really a natural extension of our mission, which first expanded in 2012 to include critical home repairs. And as we were doing that work, we discovered that the majority of our clients were actually older adults. And so in 2015, with a little bit of encouragement from HFHI, Memphis Habitat launched an official aging in place program to provide critical repairs and accessibility and mobility modifications for older homeowners across our service area. Our local effort then led to a unique opportunity to expand the work beyond just Shelby and Fayette counties. In 2018, Memphis Habitat began a multi-year project with other Habitat affiliates across Tennessee to help them launch their own aging in place programs in their respective communities. That statewide project was uniquely funded by a settlement managed by the Davidson County Chancery Court. And you'll hear a little bit more about that in our third session next week. But that funding ends in just a few years from now. So this summit is about sustainability for this work. Memphis Habitat has already served more than 1,100 older adults since 2015, and an additional 300 older Tennesseans have been served by the statewide program. Ultimately, the statewide effort will serve around 1,400 older homeowners at the end of the grant term. Unfortunately, that's not even a drop in the bucket based on the need that exists. There are literally thousands of Tennesseans, seniors across our state who are in desperate need of home repairs. And despite the progress that Habitat and other organizations have made, the resources allocated to helping seniors age in place simply are not enough. So as my team and I have been planning this event, I've often said that it's a selfish endeavor. I get in trouble for that sometimes. Of course, we hope to identify innovative funding mechanisms to sustain and continue this work. But when I say selfish, I mean selfish in regard to the older homeowners we've not yet served. This work is really all about them and about improving their living conditions and changing their lives in ways that they'd never be able to do without our help. To put it into perspective, as of 2012, more than 7,000 senior-owned homes in our service area alone were estimated to need this sort of work. Most of our aging in place clients have lived in their homes for decades, and many without the necessary upkeep and maintenance to slow dilapidation and keep the homes from falling into disrepair. The primary reason? These seniors live on approximately $10,000 to $15,000 annually. Here in Memphis, many of our aging in place repair projects cost $10,000 plus. So just, can you imagine a low income, fixed income senior being able to manage that cost? It's not gonna happen, which leads over time to those physical conditions getting continuously worse. Some of our projects have been simple: grab bars, lever door handles, ramps, and other small interventions. But many have been really critical, like repairing roofs that have leaked for years, or ensuring a senior has heat for these cold winter months and air during the peak of the summer season. All of the work that we've done has been life-changing for these homeowners. They want to stay in their homes and rarely have the means to go elsewhere. They simply wouldn't be able to make these critical home improvements without our help. I'm sure many of you have heard of Megan Sandell, whose research has been mostly about children, but she talks about housing acting like a vaccine. Her research focuses on children, but it's very similar with seniors. Your house can make you sick, right? And so if where we live can make us sick, then we believe that low-cost interventions such as these can improve a senior's health and well-being, enable them to retain their independence, and keep them rooted in their communities, right where they really want to be. Not only is this work the right thing to do, it also makes financial sense. Minimizing an older adult's frequent visits to an emergency room, unnecessary hospital visits, or early entry into nursing homes is mutually beneficial to the senior and for the healthcare industry. We want to learn to tell this story. Our goal with this Health and Housing Summit is to discuss the need, highlight organizations showing innovation in this space, and inspire action from entities that could help continue this work in Memphis, across Tennessee, and beyond. So this summit won't just be about Memphis or Tennessee, or even just about Habitat affiliates, but because we can't do it all alone. None of us can sustain this work without innovative investment outside of traditional philanthropy. We individually and collectively can do something. This summit will help inform how Habitat moves forward. And as we move forward, we hope that you'll join us. Help us determine the next step forward toward expanding our ability and yours to serve older homeowners who desperately need improvements they can't afford. So in closing, again, we're really glad to see you all here, and we hope you'll stick with us throughout the entire summit as we work our way from theory to action together. And so now, for our first panel, Embracing the Changing Tides, Preparing for Aging, Health, and Housing. We're opening this summit from a national perspective. So today you'll hear big ideas on equitable aging and learn innovative trends and strategies that scale and sustain partnerships that improve outcomes for older adults. I'm so excited for you to hear from this panel. Today's moderator is my friend, Dr. Jan Young, Executive Director of the Assisi Foundation of Memphis. Dr. Young has long been a friend to Memphis Habitat, providing practical feedback and expertise on both applications to her foundation for funding to our organization, as well as suggestions on our overall strategic goals and vision. Also, she serves on a statewide consortium that advises the Chancery Court of Davidson County on a $40 million settlement that supports aging in place repair work and other innovative aging initiatives across Tennessee. So please remember to use the Q&A function to send in your questions for the panel. And then my team will share those with Dr. Young to pose to the panel at the end of the conversation. So now I turn it over to Dr. Young.
Thanks so much, Dwayne, and welcome everyone. We are so fortunate to start this morning with a group of really talented and experienced individuals, and they really will set the stage for the entire summit. I won't read the bios for each panelist because you have that published with your agenda. And we really do want to take full advantage of our time with them today. If you did not get the message from Jessica, please, we welcome your questions. Put them in the chat box at any time during the panelist presentation, and in the interest of time, we'll take them after the last panelist has presented. We're going to start this morning with Dr. Laura Gitlin, and she's a distinguished professor. She's a director of the Aging Well Collaboratory, and she serves as the Dean for the College of Nursing and Health Professions at Drexel University. She's going to be talking about clinical perspectives, provide a case study, and touch on multiple system-based issues. She will be followed by Matt Jennings, and he's the Director of Product Development for the University of Pittsburgh Medical Center Community Health Choices. Matt will be talking about strategic partnerships, and he'll address the coordination of some of those system-based issues, including payment. And most of us are going to want to find a Matt in our community after you hear what he has to say. Then Matt will be followed by Peggy Bailey. Many of you know Peggy Bailey. She's the Vice President for Housing Policy at the Center on Budget and Policy Priorities. They are a nonpartisan institution, and they work on using data, research, and other resources to inform, hopefully, fiscally responsible and sustainable policy. She's going to address a little bit of the secret sauce of how that's made or not made, because we know that when a policy works, they're heroes to us, and when it doesn't work, we get really frustrated with some of the care we're trying to provide. Then finally, we have Sara Cantor, who's the Executive Director and co-founder of the Greater Good Studio. Now, many of us have spoken about patient-centered care, client-centered care, but we've done our work often from only the lens of our discipline or our institution or our community, and many times without the inclusion of the people we're privileged to serve. Sara's team, and Sara, leads human-centered design in a way to provide data and anticipate collateral consequences of actions and decisions we make, including policy. So now we're going to start with Dr. Gitlin.
Thank you so much, Dr. Young, and thank you so much, Dwayne and Chris and others at Habitat for Humanity, and to the sponsors for this incredibly important state of the science critical conversation that's overdue and needs to move forward with rapid speed. If I could have my slides and see them, that would be terrific. So I'm going to kick off, as Dr. Young said, by talking about the intersection of housing and health and examining the lived experience, if you will, of an older adult in the housing that they've lived in for over 40 or 50 years. And I'm going to draw 6 points, pretty simple, straightforward points. And I think this case does frame some of the arguments that we need to make, not all the arguments, but some of the arguments that we need to make and the considerations that have to be given. So next slide, please. So I'd like to introduce you to Mr. and Mrs. Smith. Mr. Smith was discharged from a hospital following a double knee amputation. Ambulance drivers drive him and his wife home, and when they arrive, what do they encounter? A row home in a low resource neighborhood, steep steps, and no rails. The ambulance drivers have to call for help to carry Mr. Smith, who's a very large man, up the front steps to get him into this home with his wheelchair. When they do so, Mr. Smith is placed on his sofa, and he does receive a commode during hospital discharge, and that's positioned nearby him. He lives in a 3-story home. He does not have a first-floor bathroom, and his bedroom is on the 3rd floor. Mrs. Smith has a heart condition. She's not supposed to climb steps more than once or twice a day. She has to ascend steps multiple times daily now to obtain clothing and other needed articles for his grooming and changing and so forth. She's unable to help Mr. Smith transfer off the sofa where he has to sleep. And because they were discharged on a Friday and there's no one to help over the weekend in terms of home health, they're rather stuck. They're in their 80s, they're African American, and they both live with multiple comorbidities. They are left on their own to figure things out. No one asked the Smiths about their home environment. No one asked Mrs. Smith about her own abilities and health problems. They are unsure to have Mr. Smith even travel to his doctor's appointment for follow-up because of his double knee amputation. Their housing situation places them both at risk for hospitalization, falls, social isolation, poor quality of life, and I could go on. Mr. and Mrs. Smith was actually one of the first couples that entered one of my randomized trials, and very sadly, over 35 years ago. But I can tell you that I met Mr. and Mrs. Smith again, a different Mr. and Mrs. Smith again, just recently in a new study. So not much has changed for people like the Smiths. Next slide, please. So my first point, drawing on this case, and clip, please, is that housing matters to health and the ability to age in place safely and with like quality. So unable to enter home because of mobility challenge is very common among older adults as they age with different kinds of ambulation problems. Next slide, please. No, excuse me, next, yeah, click. These kinds of steps are very common, torn, uneven, that present a serious fall risk. Click again, please. And here you see a home in which, very traditional in Philadelphia, in our row homes, in which the male ends up on the floor. This is a home with a woman who uses a walker. She cannot bend down and she misses her doctor's appointments, and they're wondering why she misses them. And also she misses paying her bills because she is really dependent on others coming to her home to pick up her mail and sort it through. Next slide. My second point is that small changes have a big effect, and we should not underestimate that small changes that Habitat for Humanity is engaged in, as well as the big changes they're engaged in, can have a huge effect on the ability of somebody to age in place, to avoid hospitalization, to avoid a fall. A lever, such as you see on the left-hand side of the screen, was used to enable a woman who had a stroke and could not open the door of her apartment because she no longer had the strength to do so, to leave her apartment to go downstairs to play cards. The stair glide that you see here is one that was eventually installed for Mrs. Smith to enable her to safely go up and down the stairs until a first floor commode could be, a first floor bathroom could be installed into their home. And then here you see on the right-hand side, another gentleman in one of our studies who received all sorts of very low cost, different kinds of assistive devices to enable him to bathe independently as a 95-year-old gentleman who had a stroke. Next slide, 3, please. My third point is that we have very strong evidence that attending to housing, both in terms of home repairs, home modifications, and assistive devices, and health, can lead to less disability, less depression, lower the risk of mortality for years beyond when the intervention is made, decreased hospitalizations, and importantly, cost savings to Medicare and Medicaid that outweigh any cost in training people in these different approaches to look at housing and health in their intersectionality. Next slide, please. My fourth point is that in looking at housing and health, we have to adapt what is known as a person-centered approach. What does that person need in relationship to their home environment? And what do they want to be able to accomplish and need to accomplish? And then tailoring strategies to who that person is, their environment, and their preferences. And yet simple questions and straightforward observation can get at the heart of the matter very quickly. Simply asking Mr. and Mrs. Smith, or in this case, Ms. Bell, are you able to do what you want to do in your home, has been shown in research to go a long way to understand if people are able to accomplish what they need to accomplish in terms of daily activities and what they want to accomplish. Are you able to carry out self-care and other activities? Has been found in research to be one of the #1 questions that can predict disability, functional decline, and mortality when the person says no, they are unable to carry out self-care and other activities. And these are simple questions that could be asked in primary care and in hospital discharge, for example. However, obviously, we have to be prepared to answer. And then making observations using what do exist as standardized environmental assessments to understand how a home environment supports or does not support the daily ability of individuals goes a very long way. Think of the cost savings simply from delivering Mr. Smith from the hospital to his home we could have had if a therapist, for example, was able to go out, or home care was able to go out prior to his discharge to observe his home and make plans for a stair glide, a ramp, and so forth for him to get into his home. Next slide, please. The fifth point is the fragmentation of our system, and I know Matt and others will be going into more depth about this, really penalizes the Smiths. We don't have any one-stop shopping. Who should pay for housing needs that affect health? Not only home modifications and assistive devices, but home repairs. When we see the intersection of how conditions affect health, who should ask about functioning at home and address the Smiths issues? It is not being asked in primary care. It was not being asked at discharge for Mr. Smith. And then finally, who should coordinate home modification needs, including the finances, the access, and the training in the use of a stair glide or any other piece of equipment? My sixth and final point. All of this means that when we think of the intersection of health and housing and how it affects individuals, and we think of payment models, we must also think of how we are going to prepare a workforce to understand the social and structural determinants of health, including the role of zip codes in shaping how people fare, as well as their housing conditions. We have to prepare a workforce to assess the impact of housing on health and self-care for their clients and their patients. And we have to prepare a workforce to help older adults achieve their functional goals, what they prefer to be able to do in their home through a person-centered care approach that leads to a tailored treatment plan, if you will, that addresses their preferences and needs and abilities. And so next slide, please. To conclude, I guess I would want you to take home from this that housing matters, as this panel, as well as our foray into other issues throughout the sessions that will be held, will show that housing matters to health and aging in place with life quality. And that I'd like you to understand that we do have evidence-based approaches to help people who are living in aging homes age better in that home. One of the things I know that we will be discussing is the role of foundations. And one area that I see a clear role for foundations is to help support large demonstration projects that look at, examine, and test different implementation strategies and scaling of our evidence. Because right now, Mr. and Mrs. Smith would not get any of our evidence-based programs unless they're enrolled in a study, which is how they did get their stair glide and other needed equipment and home repairs. And we need demonstration projects integrating housing considerations in primary care, hospital discharge, and in the health system at large. And I know we're going to get into more detail as to what that might look like. And with that, next slide is just a thank you for the opportunity to share the story of Mr. and Mrs. Smith, who really represent many millions of Americans who are aging in old homes. So thank you.
Thanks so much, Dr. Gitlin. You know, you've touched on some really important issues, and I'm sure all of us have experienced a Mr. and Mrs. Smith in some form or another. And, you know, I certainly heard your challenge to the philanthropic sector. And then I know that there are people out there who are wondering, okay, she's right. and it makes sense, but how in the world are we going to get that paid for? And now we're going to turn it over to Matt Jennings, who's going to tell us his approach. So Matt.
Thank you very much, Dr. Young. Good morning, everyone. My name is Matt Jennings. It's always wonderful following Dr. Gitlin because she really understands the space and sets the stage well. So I work for UPMC. It's an integrated delivery and finance system in Pennsylvania. And this just means we have both a health insurance plan and a provider system, which includes 40 hospitals, 700 doctor and outpatient sites, and we employ over 90,000 people here in PA. I was employee number 2 for our Community Health Choices plan, which is a Medicaid managed long-term services and supports plan. So that means something to some of you, not a lot to the rest of you. So in short, Medicaid means the people we serve are living in poverty, and long-term services and supports refers to the tools we use to support them in their day-to-day lives. And for our home and community-based participants, about 85% of this is called personal assistance services, which is assistance with activities of daily living like dressing and eating. We've gone from $0 to $3 billion in 3 years, and we now have 123,000 members that we serve in Pennsylvania. And I really see my role as looking 3 to 5 years down the road. So much of our focus is quarter to quarter. I think it's important to keep an eye on the long view. And so one of the interesting things about working at an integrated delivery and financing system is because of fragmentation and systemic system flaws, there's real structural tension, and it feels almost schizophrenic at times, because when I'm doing my job well at the health plan, oftentimes I'm actually going to make the system side lose money. We're all friends here, so I can say that. The reason I don't have slides is so I don't leave a paper trail. But the good news is when a program is well designed, when payments are value-based and incentives are aligned, the benefits do far outweigh the system losses, and it's a very powerful thing. So Community Health Choices, which is a program I work on, which supports older adults and people with disabilities, it actually falls into one of the most advanced alternative payment methodologies, which is called global capitation. And so folks might be hearing, we're trying to move from what's previously called fee for service, which you get paid for every X-ray, every widget, to more of these advanced payment methodologies. And this means we get a set number of dollars for every participant that we serve. And if we're being proper stewards of this capitation, our first role is to reduce what we call unplanned care. That's things like emergency room visits, inpatient visits, skilled nursing facilities is traditionally what we think of unplanned care. But looking forward, and especially in the context of this discussion, it also includes things like the fireman being called to help somebody down the stairs. It includes somebody living in a nursing facility when they could be safely supported in the community. Looking even further down the road, it's things like preventative interventions like lead remediation and healthy housing, even early childhood education. The third trimester you spent with your mom actually has a larger impact on whether you'll have depression or anxiety as an adult than most people realize. And so we really need to plant those seeds now so future generations have shade. And so here at UPMC, what we're doing and what we need to keep doing is working with our partners to build and test evidence-based interventions. I think one of the shining jewels that we have at UPMC that we love to talk about is our program called Cultivating Health for Success. We started this almost 10 years ago, targeting people that were homeless, fit the HUD definition, so very a lean and narrow definition. But we did find that even including the cost of the housing and the cost of the interventions, that overall this decreased the person's cost of care. It was a housing first model. We've now really kind of put this through the ringer, so we know what works, what doesn't work. And while we see some costs increase, obviously housing and primary care physician appointments, which is actually good because that's planned care, we really saw a reduction in ER and inpatient visits. So it's an example where it works well, and we're now just starting to expand that beyond the HUD definition of homelessness to folks that are housing unstable, such as people that are couch surfing or have multiple changes of address in a year. Another areas are nursing home transition programs. So this has been heavily informed by Dr. Gitlin's work in Able and Capable. We've just moved to value-based payments here. So moving from a fee-for-service payment arrangement to case rates, even adding on follow-up visits for up to a year to make sure that our participants stay safely in the community. The big question though is how to scale this. From a macro level, this is where the fragmentation in our system is really a challenge. So we need more integration and we need more alignment. At the extreme, this looks like single payer. It's no coincidence we stand alone in our lack of a true public option and also alone in our dismal outcomes to spending an exorbitant amount of, despite spending exorbitant amounts every year. I know single payer is kind of a dirty word amongst us healthcare executives, but I think the evidence is a little overwhelming. I know that's a lofty target. So in the interim, we do need more consolidation and integration, and we need more flexibilities. We hear all the time, you'll hear it during this whole summit, that housing affects a person's health. But we as a health plan, we actually still can't even pay for it. And so that obviously is going to be a barrier to paying for housing. On the micro level, we really need these replicable evidence-based interventions that are consistent, that have well-defined measures, and I think very importantly have well-defined populations. Again, the fragmentation in our system is a challenge, and the benefits can sometimes accrue unevenly and with low or no correlation to investment. And so, for example, if we did, build a great, healthy, accessible apartment unit for one of our members, they can switch every month. And so, the next month they go to our competitor, and fortunately it's not great for us. We have a profit motive in our healthcare system, and we need to work within that. So summarizing, I think what's really important is to continue to have these conversations, to share what's working and what's not working, to talk about where we have specifically designed interventions for populations that work, that can be replicated. But we also need to, I think, acknowledge and find a way to fix or overcome these systemic flaws that really hold us back from doing great healthcare. And this means aligning incentives, encouraging investment in things we know that works, and really taking that long view, looking 60 years down the line. There's a lot of great work going on in early childhood, but it's also a lot of great work going on in the aging space right now, things we can do to help keep people safe at home. And so really thank everybody here for your attention. Thank you in advance for your great questions. This is a great conversation to be having, and appreciate being a part of it.
Thank you, Matt. And thank you for referencing Dr. Gitlin's work. And for everybody, please feel free to Google her and read those research studies that she's published. The other thing, Matt, I'm going to give you a pass because I heard you say, and I know everybody else heard it too because it's on tape, you found one more thing to blame mothers for in the third trimester, but we'll give you a pass on that one. Now, Matt has a unique relationship at UPMC with the Department of Human Services. So please visit that website and look at what they're doing with many of their strategic partnerships. Now, Matt referred to some things that are challenging to his infrastructure and the systems he's created. As we discussed earlier, so much is influenced by policy. And so that's why we have Peggy Bailey. Peggy, you're on.
Thanks, Dr. Young, and hello, everybody, and thank you for inviting me to speak here today. So to complement, so Matt gave you a good overview of the challenges within the healthcare system and the opportunities there. And I, through a policy lens, am going to talk about the housing side of the world. What COVID has definitely highlighted for all of us is what we really already knew, but now we can see play out in these months since the pandemic started, that seniors, and particularly low income seniors and people of color are disproportionately impacted by COVID, and a lot of that lies in the disparities that exist within the housing and healthcare spaces. What is important is before the pandemic, we've been in an affordable housing crisis for quite some time, and there's a need for significant resources to pay for housing itself, to help end homelessness, to help people who are currently in housing be able to afford their housing better. Too many people pay more than 50% of their income on their rent, and that puts them at risk of homelessness, and also reduces what they can spend on other things like healthy food and adhering to medical advice. And then there's also significant housing quality issues that exist. And what in the senior space in particular, what we've seen is that people with low incomes don't have the same options that their peers have who have higher incomes to be able to stay at home. And that, while before we thought, okay, well, they're in a nursing home and maybe that's not ideal, but they're safe. What COVID has shown is no, people aren't safe in congregate settings if they don't need to be. And it's not as if flu epidemics didn't happen in nursing homes and other contagious illnesses didn't spread in nursing homes before. But now with COVID and the tragic outcomes from COVID, we can see in real time the disparities around mortality that it can exist for people that are that are in institutional care, and see the need that, yes, there's some people that may need nursing home care, but there's a lot that we can do to help people stay at home and age in place. And so while there's definitely a need for flexibility in the healthcare space, the burden for housing shouldn't be on the healthcare system. We have a housing system that knows how to get people assistance and that can help improve people's housing situations. But the housing world doesn't have enough resources, and that's where we really need the healthcare world to engage with us, particularly at this unique moment in time where we think that we could have significant investment at the federal level on housing. The most recent relief package that passed has a $25 billion investment in emergency rental assistance. That's the biggest housing investment, direct housing investment we've ever been able to get in an emergency bill, and says so much about the recognition in DC in a pack. I mean, think about it. In a package that was scaled down from $2 or $3 trillion down to $900 million, that was scaled down to less than $1 billion, to have or to less than $1 trillion. That sorry, the trillions and millions get all messed up. To less than $1 trillion, and still to include a significant investment in housing, shows that at the federal level there's a recognition of the role that housing plays. And so the way that I want to hone this down to more specifics is to highlight public housing as a microcosm of what we see across the housing world. And I'm doing that because public housing often gets left behind in the housing conversation. We talk about people who are currently in housing and sending resources to them, and then we talk about the need for more affordable housing supply and voucher assistance to help pay for rent, but public housing rarely gets talked about. And if we're going to make a significant investment in housing, public housing needs to be a part of that equation. We know that about 1.1 million households are led by someone either who are over 62 or have a disability. So when we put that together, since many people with disabilities have some of the similar needs of people who are over 62. And for those of you who aren't familiar with the housing space, when we talk about seniors, we say, 62 is our cutoff age, not 65. That's what makes people eligible for that's the age that makes people eligible for senior programs. So what highlights the fact that the healthcare world isn't going to be able to fix the housing world's problems is, there are estimates that upwards of $70 billion, if not more, is needed to revitalize public housing across the country. There are reasons to think that 70 billion is even a low estimate. In New York City alone, the estimates go up to as high as $40 billion to be able to renovate public housing. And those renovations are mostly about the health care and accessibility issues that exist within our aging public housing stock. There are accessibility issues. New York City right now is in a settlement agreement with the federal government because of mold and lead, and those things are bad for children, but also bad for seniors. Another component of the housing world that's highlighted in public housing is location. We know that public housing is disproportionately located in communities that have been disinvested in and are often are disproportionately have a disproportionate share of people of color in them. So we know that racism and discrimination in the broader culture has impacted public housing and caused public housing to be segregated into these places that have low investment, which also impacts their people's access to healthcare and quality healthcare. We know that early on in the pandemic, we've seen reports out of New York about the disproportionate outcomes between people that had access to certain hospitals and others that had access to hospitals that were largely in communities of color. And so those four things: accessibility, quality, location, and access to healthcare are all we can see in public housing and are all issues in the broader housing system. The challenge is at the federal level, just like with healthcare, housing is very siloed. We have specific programs that are for seniors, and within that specific program, parts of it that deal with capital costs, parts of it that deal with rental assistance costs. And we have the public housing program at large. We have so many silos, it's ridiculous. And it also makes it hard for the other systems like the healthcare world, child welfare world, others that really want to engage with housing, to be able to know where the right entry point is to start to have collaborative conversations across the housing world. As Dr. Young mentioned in the beginning, too, this is what leads to a lot of the administrative headaches when we try to create new programs at the federal level. And unfortunately, too often, we're creating new programs at the federal level rather than investing in the current ones, which then just adds to the administrative barriers. The last issue that I want to raise is in the homelessness space. So separate and apart from the housing stock and rental assistance world is the homelessness world. And over the last decade, we've seen small but steady increases in the number of seniors who are experiencing homelessness, to where we're getting really close to about 3% of the homeless population are seniors. And that's pre-pandemic. We know that during the pandemic and throughout 2020, homelessness has increased, and we don't know exactly how much, but I fear that it is significant. So what can we do then to given all of these challenges? And I think right now we're at, I'm actually glad that this conference got postponed to this week, because this is probably I can give a much more optimistic view of where we are for the future than I might have even, maybe a week ago. And that is that there is gonna be a conversation at the federal level about increasing housing assistance and reducing homelessness. But now is the time for us to be, so now it's even more urgent in the coming months to be able to articulate some specifics about you know, but being bold about what we're talking about, that this is a chance to break down some silos within the housing and health world, really connect people to talk, to do what Laura talked about around person-centered care. Like, how do we really reorient the silos that currently exist, so that instead of looking at putting money in a bunch of places and hoping that at the local level they're delivering person-centered care, can we relate that concept to the federal level, so that the program design can makes it easier at the local level. The other big piece for the housing world is now is an opportunity to advance a universal voucher program, that so that everyone who is eligible can receive rental assistance at a minimum. Right now, with current funding, only 1 in 4 households that are eligible for federal rental assistance receive it. You know, if we can in the near term make great strides to get that number to 50 and 75% of families who are eligible receive it, that could make a huge difference in this conversation back and forth between the healthcare system. The last piece is, if an infrastructure package moves forward, joining health and housing advocates alike, joining in the need for improved housing quality and centering public housing in that conversation. That we need federal investment to rejuvenate public housing and affordable housing broadly, to make sure that people are living in safe places that aren't causing them to have greater asthma episodes, threatening their respiratory outcomes, have access can live in places that have access to nutritious food and better health services. So those are the things that I think this opportunity, it's really important to think about the things that we're learning at the local level that can inform the federal level in very short order, so that we don't miss this opportunity in time. What I keep saying is, you know, in my background before becoming vice president for housing at the center, I worked a lot in the intersection of housing and health, and don't want this moment for housing to be like the early 90s were for healthcare, where we talked about the need for healthcare but couldn't close the deal on expanding access to health insurance. And it took years before we even just did that for children. We don't have a decade to get to some incremental outcome. We want to get to incremental outcomes now, so that in the next, you know, in the near term, we have a universal access to rental assistance, but also improve the quality of housing. And I think both are on the table in the next, in the short term at the federal level, given the politics that are in DC. And Dr. Young, I'll pass it back to you.
Thank you so much, Peggy. And thank you for ending on a note of optimism after we got depressed from the facts, and also the challenge to us. All of us who've studied healthcare economics understand that often federal policy will dictate practitioner behavior or the way things are reimbursed. And Peggy's not giving herself enough credit, but she's done a lot of work at the center and with her colleagues, and she is partially responsible for that amount of money being available for rental assistance, and we thank you for that. Now, we've had a wonderful conversation and a broad overview of the challenges that we face in health and housing. And so Sara, and oh, by the way, before I go to Sara, if you have not gone to the center's website, please do so, because there's a wealth of information on the website, not only for aging issues, but housing issues that affect all ages within the spectrum. And there's also other information about not just housing. Now, talking about websites, I invite you to go to Sara Cantor's website. Now, I'm not going to say it, because if I say it, I'll probably get in trouble, but everybody's got to be excited to hear from a woman who has the courage to put on her website page the way that she describes herself and her team. And they collectively describe themselves as I can't say it, bleep, bleep, optimists. So go look at the website. Sara, you're on.
First of all, it's not that bad. Although thank you, Dr. Young, for giving our audience some viewer discretion. Thank you very much. I'm actually going to share my screen. So let's take just 1 second here. And great. Please, somebody flag me if you can't see my slides. Otherwise, I'm going to assume that they are working. So thank you to Dr. Young, and thank you to all of our wonderful panelists. I'm very excited to have a discussion with you after this. So I want to start by kind of stepping back a bit, bringing us down to kind of the human level, if you will. Aging is a universal experience, if we're lucky, right? Aging happens to all of us if we get, if we are fortunate enough to make it that long. And yet, what I see and what I've been hearing in the panel so far is that older adults are so often not supported in our society, right? Dwayne kicked us off by talking about the older homeowners in Memphis who are dealing with high rates of poverty and had been living in their homes without updates for years or decades. Of course, Dr. Gitlin told us about Mr. and Mrs. Smith, who I'm still thinking about. Thank you for that important case. Hearing about how they were left on their own to figure things out, and the fragmentation of our system penalizes them. Matt told us about the unplanned care that older adults experience and how often they move to nursing homes earlier than is necessary. And Peggy told us a fairly, there were some harsh facts in there about seniors of color and low income seniors. As we know, the pandemic has caused high degrees of lack of safety in our congregate care and nursing home settings, as well as the segregated public housing with low investment and the increases in senior homelessness. These are all examples of seniors being excluded, devalued, stigmatized, or simply forgotten about. And actually, when it comes to philanthropic dollars from America's largest foundations, less than 1% of the funds go to causes related to aging. So often the case is made for more compassion, right? More helping. But I would suggest that this is an uneven power dynamic. It seems to say we should help those older adults who cannot help themselves. I would suggest that there's even a narrative in our society that older adults are a burden, a problem that we need to solve. And I believe that this narrative is kind of a cultural belief and a root cause of many of our systemic challenges. And so I would like to suggest an alternative narrative. I would like to suggest that older adults are an asset. In fact, I would say that they are our greatest asset in the quest to design a more vibrant and equitable society. And here's why. So not only are they full of wisdom and experience, yes, they literally represent our future, but also when we can learn from them and create communities that work for them, we can actually improve the experience of living for everyone. Here's why. There's a phenomenon called the curb cut effect. So learning from older adults is a great example of the curb cut effect, where designing for and with those most marginalized creates ideas and solutions that benefit everyone. So some folks might be familiar with this term. It was coined by Angela Glover Blackwell in Stanford Social Innovation Review about 3 years ago. She has an article of the same name. And this term is referring to, of course, these ramps that you can see in the slide that have been cut into sidewalks since the 1970s, but really became universal with the Americans with Disabilities Act in, I believe, 1994. And you can see how a curb cut would benefit someone who is using a wheelchair, right? And actually wheelchair activists or disability rights advocates, I should say, in the 70s were pouring their own concrete to actually demonstrate, this is how badly we need ramps in order to get off the sidewalk and move about our lives. So certainly these curb cuts have benefited people who use wheelchairs. But if you've ever been pulling a suitcase, pushing a stroller, pushing a heavy cart, using a cane, riding a bike or a scooter or a skateboard, you have also benefited from curb cuts. You've probably benefited from the curb cut effect if you've done any of the things that I just mentioned, right? And that, I think, is the key, is that curb cuts go far beyond the idea of, it's not just about curbs, basically. So if you go to the next slide, there are so many examples of how the curb cut effect has benefited us in society. So for example, seatbelts were originally designed for children, but of course they've saved countless lives, both young and old. The football huddle was actually created by students who are deaf or hard of hearing at Gallaudet University in DC. But of course, the football huddle works for people who are speaking, not just those who are using American Sign Language. There's a story from OXO Good Grips, a commercial example on the bottom left here. This is a line of very ergonomic kitchen tools, which if you've ever been in a Bed Bath & Beyond, you've probably seen OXO Good Grips. But the story goes that Sam Farber, the company's founder, was actually wanted to create a can opener that his wife could use, and she has reduced hand strength. So of course, designing for her more acute need led to products that make cooking and cleaning easier for all of us. And finally, subtitles and closed captions, which were also originally designed for deaf and hard of hearing communities, but of course benefit so many people, like those who are learning a new language, students who benefit from increased focus and concentration when viewing subtitles on their teachers' videos. Now, it may seem obvious to design for these acute needs, but quite honestly, we don't always do it. And I think there's an important barrier. If you go to the next slide, Angela Glover Blackwell has a beautiful quote in her piece. She says, "There's an ingrained societal suspicion that intentionally supporting one group hurts another, that equity is a zero-sum game. In fact, when the nation targets support where it is needed most, when we create the circumstances that allow those who have been left behind to participate and contribute fully, everyone wins." And this, I believe, is why older adults are such an asset, because when you design for them, you design for everyone. So if we go to the next slide, I wanted to share a project that I worked on in the past couple of years in California. I am in Chicago, but this project took place in California. It was when we used to do something called travel. California's over 60 population is projected to diversify and grow faster than any other age group. As you can see here, this is their Department of Aging website. By 2030, 10.8 million Californians will be older adults, making up 1/4 of the state's population. So if we go to the next slide, back in June of 2019, the governor signed an executive order, Governor Gavin Newsom, calling for a master plan for aging. And the goal here was to help the public, private, and social sectors to coordinate and respond to the diverse needs of seniors across the state. And when this happened, our client, the SCAN Foundation, was ready. Next slide, please. The SCAN Foundation's mission is to advance a coordinated and easily navigable system of high-quality services for older adults that preserve dignity and independence. And SCAN had been advocating for a statewide master plan for years. They also recognize that the people setting regulations and policies are often not the ones most impacted by them, right? So the SCAN Foundation wanted to ensure that the commission was informed by the voices of those most impacted. So instead of a traditional planning exercise, which might prioritize system needs, they had a vision that policy should be directly informed by the lived experiences of older adults, and that if we elevate their voices and honor their realities, that they could meaningfully contribute to the policy design and solution finding process. So next slide, please. You may be wondering, what do I have to do with any of this? I don't work for the SCAN Foundation and I'm not in California. So I run Greater Good Studio. We are a human-centered design firm dedicated to putting people at the center of social change. And we are not content experts. I am not an aging expert or certainly not a policy expert. But while we don't write policy, our work inspires the design of policies, programs, and services. Human-centered design was actually originally created as a more of a corporate innovation process in order to design products that would be used by individuals. So not unlike the OXO grips example that I shared earlier. What it means is understanding individuals, their lives, their behaviors, their attitudes and aspirations, not simply asking them what they want in sort of a market research way, but really getting to know them and understand their unmet and unarticulated needs, and then translating those needs into new ideas. Now, human-centered design is often done at the kind of individual scale, but this was a statewide project. And so we had to ladder up and look for those universal needs that could sort of go across urban, rural, suburban, and tribal places that could be relevant to different communities around the state. So in other words, this was human-centered design at scale. Next slide, please. Our process began with ethnographic research. So we did day in the life observations with about 20 older adults and their care teams. So people can't tell you what systems and structures they need to thrive, but they are experts in their own lives. And they can certainly tell you that the bus stop is too far away to walk, that their housing application took years, or how losing the ability to drive was both a logistical challenge and profoundly emotional. Next slide, please. We met with Norma, who lived in a rural part of the state and had received a cancer diagnosis. Her radiation appointments were every day for a month, and they were over an hour drive away. This is her quilting group, and they organized themselves. And so someone different signed up to take Norma to radiation every day for 30 days. This was the kind of resilience in the face of trauma that we heard about in communities across the state. Next slide. We synthesized all of these learnings and created a presentation around this framework. These, we found, are the pillars that are sort of necessary for someone to thrive as they age. The physical environment, which of course includes housing, transportation, and urban planning, supportive services such as healthcare and social services, and social and emotional well-being, which encompass things like caregiving, work, volunteering, and maintaining social connections. We knew that the first two would be critical. We didn't anticipate the third, social and emotional well-being, to be quite as prominent, but we found that it was just as important in quality of life as the other two. And then next slide, we took the framework, some insights, and some prompting questions out, and we did 5 community design workshops with older adults from our research, plus relevant stakeholders like healthcare providers, local businesses, aging and disability advocates, some elected officials showed up, some local media showed up. We did these in 5 communities around the state. Over 500 people participated, and we generated over 1,000 ideas. These were ideas for programs and services and policies, partnerships, campaigns, messages, regulations, events, lots and lots of ideas. I'm telling you, give people a safe environment and spark their creativity, and they will blow you away. Next slide, we synthesized patterns from the workshops and put together a final report with 28 human-centered strategies. For example, in the physical environment, one of the strategies was to design for mixed age, mixed ability neighborhoods with amenities that meet people's physical, social, and emotional needs. For each strategy, we included illustrations as well as concepts at the policy, program, and tool levels, as well as analogous benchmarks from across the country. We also suggested in the physical environment coordinating transportation options across agencies, streamlining housing application processes, designing intergenerational housing, and co-locating services for older adults and children. Next slide. We even hosted a panel discussion with some of our research participants at a governor's forum on aging, where they got to share their stories directly with policymakers. And actually just this month, in January of 2021, The California Department of Aging finally released their master plan. It's very detailed. It has lots of metrics, lots of dashboards, but many of their strategies and tactics are parallel to the ones that we brought forth. Now, final thoughts. I actually don't think I have another slide. Well, we could pause for a second. I would just say, and I'd like to kind of conclude by saying that older adults truly are an asset, and we couldn't have done this project without their active engagement. They were, we listened to them, we worked alongside them in an atmosphere of mutual respect. And I believe that we, through that experience, had created better ideas for everyone. It's the curb cut effect. Yes, we should value seniors, but not just because we care about them as beneficiaries. Their lived experience is critical. And when we design policies and systems for them, they will benefit all of us one day if we're lucky. Lastly, if you would like a copy of our report, Elevating Voices, feel free to email me. And thank you so much.
Thank you so much, Sara. And as one of those chronologically gifted adults, I thank you on behalf of my peers for considering us assets. So I appreciate that. Now we're going to go into our question and answer session now. And we've got some. One of the questions that came across, and anyone feel free to answer this, how do we address possible fragmentation between housing sector and health systems in the hospital sector? What are a few points that we can take from this presentation? Anybody?
I could start and then see. So I think that we have some models in the homelessness world about how, and Matt should go, yeah, in the homelessness world on how to do this. Being able to do data sharing across systems, which can be hard, but is doable. It just requires some patience. And if you're working with a healthcare system, helping them understand the limitations that maybe smaller providers don't have around data, and also recognizing what do you need to know, because the healthcare system is going to be the owner of the data, and the sharing back and forth has restrictions, but it's, like I said, isn't impossible. But what in the homelessness space in LA anyway, there's data sharing that happens between the hospital, and this is in a frequent users context. So if there's someone who's frequently using the hospital, they can flag that person. For the homelessness sector, within a very short amount of time, a homelessness caseworker comes to engage that person, and then they begin the process of trying to house that person as quickly as possible with the resources that are at play. So that's what's required. I think it's really important to understand that one sector shouldn't try to do all of these things. Each sector has its expertise, and so it's about doing the hard work of partnership to try to align resources. But as I talked about in my presentation, then we have this issue of restricted resources, especially on the housing side. And so that's where we can do these things, but we also need advocacy at the state, local, and federal level to increase housing resources so that people don't have to wait for the housing component of any of this coordination.
Absolutely, and I'll build on that a little bit. And as several speakers mentioned, this is again where fragmentation can really hinder. And as Peggy mentioned, one of the ways to get around that fragmentation is through data sharing. It is incredibly difficult, however, I will say. We now at UPMC, having added on this long-term services and supports program, we finally have both sides of the coin when it comes to data. So previously, the long-term services and supports program was administered through the counties, and we had no idea what was going on. We had no insight to the data, but we do now know very preliminarily. We've only been live for 3 years now, or we've only been live actually 1 year statewide, but 3 years in the Southwest. We do know when a participant is aligned, they have better outcomes, and we are looking forward to proving more of these kind of theories and theses as we move forward. So one example from the food as medicine area, which I think is along a similar track is housing, where we're realizing that food has an outsized effect on somebody's health. We're finally starting to get SNAP data from the state. And what I would love to see is if we could get housing data as well. because my theory is that our participants that are living in, low-income housing tax credit properties, specifically designed to serve people with disabilities or older adults, the housing is going to meet some of those activities of daily living needs. And, the theory is these participants will be better managed. But without that data and 123,000 members, it's very hard to go through and pull out those correlations. And so continuing to share data and knock down those barriers across organizations. I think employment is another huge area of opportunity. What are those levers, and how do we correlate that to outcomes? And then how do we design interventions to pull those levers is going to be critical moving forward.
Dr. Young, may I chime in just from a practice perspective, and to add what Matt and Peggy said, but from a different perspective is, I have just several points I wanted to say. And one is that we do have transition care models that have been tested, but unfortunately, they do not integrate a housing and environment perspective, nor do they focus on functionality. So they've shown good outcomes for other kinds of issues of medication management, for example, moving a patient from hospital to home. So building out those models, actually, it was your point, Matt, taking what has worked in one area and then adding to it, and having a health and housing framework, I think would be a terrific win, if you will, because the elements of the transition models that we know are effective exist. But again, they do not address function at home, ability to age in place at home. And then to that point, really taking a hard look at discharge planning. Discharge planning right now does not include an understanding of where the person is going to go after they leave the hospital. Discharge planning does not identify whatever you want to say, a primary care giver, a primary care partner, a family member who is going to assist. So that is, again, could impact how people move from, hospital to home. And importantly, from a policy perspective, not every older adult needs intensive care or intensive transitional care planning. So an Australian study that's recently been tested from hospital home, they found that the cost savings and the benefit were for individuals that were older adults who were at most risk, fitting certain, using and we have these well-designed risk profiles. And that for older adults who were not at risk for rehospitalization, for example, who were not a double knee amputation and had difficulties with ambulation, they did not need intensive transitioning from hospital to home. So from a policy perspective, it's not every older adult that has to be discharged, and we could begin to triage and identify those who were at most risk of not functioning well at home because of their housing at discharge planning. That doesn't necessarily address the fragmentation from a financial perspective, but certainly I do think that there's low-hanging fruit we could do now to ease the transition from hospital to home, particularly for those at most risk.
For discharge planning resources, you might want to go to, for anybody on the call and the webinar, go to the rehab folks and the physiatrists. They do a good job with the interprofessional team prior to discharge planning. And as we talk about funding, there's been several questions that have come across about funding. Matt, one question was directed specifically to you about, did it make a difference that your state did not take Medicaid expansion?
Well, it only makes a difference in respect to the population that's covered. I should say, if you've seen one state Medicaid program, you've seen one state Medicaid program. So it will definitely be different from state to state, and different states provide different flexibilities around housing benefits. But in terms of the Medicaid expansion, that will more or less determine who is actually covered by the program, I think, versus the actual benefits that are available.
Thank you. And to Peggy or anyone else, do you have any proof of concepts in place for a capitation model is funding home modifications?
Matt, do you want to take that one?
I would, this for us would be wonderful if something like this existed. I would say, unfortunately, it doesn't. The closest I think we've come is the work that Dr. Gitlin has done around just some low-level interventions. I think that's there. Well, was Health Affairs. I think it was published a few years back around the capable model and the interventions that work there, really coupled with an OT. But around home modifications, I think there's still a ton of work to do. And one of the big difficulties is, again, going back to the fragmentation. There are 3 separate plans in Pennsylvania that are providing the Community Health Choices program, or participating in the Community Health Choices program. And they all do home modifications, but they also all have members that can switch month to month. And the average cost of a home modification is $10,000. And it's incredibly expensive, and there's not a lot of data around the ROI on that, and also with the risk that participants can switch the very next month. You can imagine there are a lot of internal barriers to actually getting home modifications done. Fortunately, in the nursing home transition program, we have an economic incentive to do it. It's less expensive to serve people in the community, and we do have those numbers, and are looking ideally to move to a value-based arrangement, but it's incredibly difficult because it's an intersection of not just housing and health, but local construction and building codes, and a lot of really kind of difficult, hairy things.
Right. You know, the connection between housing and health outcomes is longstanding. And one of the participants said, you know, the local action to inform policy may be a great path to action if there's enough stakeholders collaborating to show that it's possible. So they wanted to know who makes sense to act as the quarterback at the local level. Like, who would be the one who would champion the cause at the local level from your perspectives, any of you? Whomever wants to take that. Who would be a great champion for at the local level to inform policy?
I would say it depends on what your purpose is, right? It depends and what population and how you're facing and how the structures at play locally. If you really want to play, if the cost savings argument is the thing that you're bringing forward, then going to the highest level of government makes sense to be the quarterback, because they're the ones that see the budget on all the pieces. Because I think, you know, as you could tell from the presentations, right, there's services costs and there's housing related costs, and the housing related cost and the services related costs go in a variety of buckets, right? We didn't really talk about behavioral health costs or things like that on the healthcare side. And like I said, in the housing side, there's construction, there's rent, there's all these things. So going to the entity, whether it's the city or the county, or most often or the state, which really makes a lot of sense when it comes to Medicaid and everything, being the driver from a policy perspective, because then it doesn't matter which bucket you're saving money in and which bucket you want to add money to, and how to because they care about all the buckets. So that's what I would say is, depending upon your population, think about who is the governmental entity that cares about all the spending, and go to them to be the quarterback when you're doing a cost savings argument.
Thank you. And we have another question for all of you. Do any of your states allow lottery money to go toward aging, care of aging? Pennsylvania, apparently. Matt, I saw you nodding your head.
Yes, we have a wonderful program here called Options, and it's kind of like the Obamacare, but for functional and social services. And so if you don't quite meet the financial threshold, because we are a Medicaid program, but you need assistances, there's a wonderful Options program that's funded with lottery money here in PA.
And how about Illinois, Sara?
Sorry that I don't know.
Okay, well, you know, it's good for all of us, so we can go look, right? We can ask. That's great. Laura, did you want to pipe in?
I wanted to pipe in about something else, if you don't mind. And
okay,
that is,
sure.
and this has to do with cost. So I just wanted to say that in our first foray in terms of partnering with a AAA and their housing department. We spent no more than $500 for home modification assisted devices and had huge benefits on disability, depression, fear of falling, drop in falls, and a lower risk of mortality. The Capable project estimates about $3,000 per person. So I just want to say, Matt, that the range is, it depends, right? I mean, stair glides and so forth are maybe more, but it's a range. And maybe this is just a question I'd throw out and would want some understanding of. I think that the area agencies on aging could potentially play a key role here in terms of coordination between housing and health. And I don't know if the panelists would agree with that and what that would have to look like in terms of providing the adequate resources. But Philadelphia has had one of the premier housing departments throughout the nation. And they have been stymied in providing home repair and home modification only from funding, but not from an infrastructure point of view. But they have remained separate from health systems. And so somehow, again, I think Matt and others
are getting the hook. We're getting the hook right now.
Oh, okay.
Melanie Campbell, that's okay. Melanie Campbell from Reframe Association, and her email, look in the chat box, please, to get her email. She said that she'll be happy to talk about some lower cost ways to do modifications, very much in keeping with what Dr. Gitlin just shared with us. Now, Dwayne, I think I'm supposed to turn it over to you because you're supposed to wrap this up for our future sessions. And I want to really, before he gets on, thank you so much to each of you for sharing your time and your wisdom with us today. Dwayne?
Dr. Young, thank you so much. This was really interesting and compelling. I heard you guys talking about the consideration between around the cost of interventions. And I would have to say there is this slight difference between a true, strictly aging in place intervention and a critical repair. And that depends on the condition of the home. And what we're finding here in Memphis is that so many of the homes need roof work. We need to get it into the dry because that creates moisture, mold, mildew, the window sills pulling away from the walls. All of that creates a higher cost intervention. So that's one of the things that we are dealing with here locally. And I'm sure many of my colleagues across the country. Other things I heard, social determinants of health, functional goals of the homeowner, capitalization and unplanned care, value-based payments, a need for more integration, evidence-based interventions. People with low incomes have fewer options to addressing housing issues. The housing sector does not have enough resources, which is why we need the healthcare sector to help. Peggy Bailey said, let's not just talk about this without closing the deal. I completely agree. Sara, aging is a universal experience if we're lucky. I love it. Less than 1% of philanthropic dollars are supporting aging initiatives. Older adults are an asset, not a burden. The curve effect, we all benefit. Then someone said folks setting policy are often not the ones affected by it. That's really significant. Human-centered and the lived experience. Those are some of my takeaways. So I want to say thank you to all of you again for being with us. And on Thursday, we will have our second session, which is called Data-Driven Solutions, Critical Research that Catalyzes Community Change. And I'm hoping that I will see all of you back here again. All right. Thank you so much. Thank you to our moderator. Thank you to our panelists for their expertise. I appreciate it. See you all again very soon.